Thank you, Florian, for the kind introduction, and thank you to the organizer for inviting me to give this talk on the recent advances in macronodular adrenal hyperplasia. So I will focus on the last 2 years. So I'm currently serving in Paris, but soon moving to London in a few weeks for doing some research here at Imperial. Okay, so I will call the disease PBMAH for a primary bilateral macronodular adrenal hyperplasia, which is currently accepted terminology for the disease until now. So to give a quick definition, but not a proper definition probably, this is bilateral adrenal macronodules more than 1 centimeter in diameter and associated with variable levels of cortisol excess. This is quite vague, but until now, I cannot be more precise because we do not have any non-invasive predictive criteria or diagnostic criteria for PBMAH, and the formal diagnosis is only made by histopathological analysis of resected adrenals. But nowadays, only the half of the patients will be operated, while the other half will be managed conservatively. This is a rare disease and a rare cause of Cushing syndrome. The mean age at diagnosis is around 55 with a clear female predominance. In most cases, PBMAH is diagnosed in patients investigated for bilateral adrenal incidentaloma and less frequently in patients investigated for overt Cushing syndrome. Most often PBMAH is sporadic, but of course it can be familial. The first familial cases have been reported in 1993 with a mother and her daughter, both affected by a severe ICTH-independent Cushing syndrome from bilateral adrenal origin, both in their 40s. And since then, many other familial cases have been described, of course, raising the question of genetic predisposition. And the first genetic predisposition has been elucidated more than 10 years ago in 2013 with the identification by our group in Cochin of the germline inactivating mutations of ARMC5. ARMC5 is a tumor suppressor gene, so it follows the model of inactivation of tumor suppressor genes, namely a germline heterozygous inactivating mutation, which is present in the leukocyte DNA, but also in all nodules, in all adrenal nodules, and always associated with a somatic event, a second somatic event, exclusively in the adrenal nodules, affecting the other allele, and then leading to a biallelic inactivation of the gene. This is a common pattern of the tumor suppressor genes. Since 2013, more than 10 cohort papers have been released, and they studied the mutation rate of ARMC5 in PBMAH, and now ARMC5 is considered to be the molecular cause of around 20% of all index cases with PBMAH. And ARMC5 mutations are associated with a more severe phenotype. Patients will have a more severe Cushing syndrome with more metabolic complications, larger adrenals with more numerous nodules, and the patients are logically more often treated, whether by surgery or by steroidogenesis inhibitors. So 20% in index cases and probably around 80% in familial presentations. So we first wondered if we could predict ARMC5 mutation based on a clinical, biochemical and radiological data that we have collected from 352 index cases, for which germline DNA had been sent in our lab for the ARMC5 genotyping from 10 different European endocrinology departments. So these 352 patients were very heterogeneous including also patients with unilateral adrenal nodules and patients without autonomous cortisol secretion. But we wanted to stick to the real-life conditions of a genetic department. So in this series, 52 patients had an ARMC5 mutation, so less than 15% of patients. This is lower than previously reported because this is a non-selected population. We considered only patients with bilateral adrenal nodules and autonomous cortisol secretion defined at least by a cortisol after 1 milligram dexamethasone suppressant test above 15 nanomole per liter, and then the mutation rate raised from 15 to 20%, which was similar to the previous reports. But we also tested more stringent criteria, and the mutation rate was increasing to 25% in patients with elevated UFC, to 35% in patients with at least 4 adrenal nodules, 60% in patients with at least 6 nodules, and almost 80% in patients with at least 8 nodules. But sensitivity declined because some ARMC5 patients had a normal UFC that was quite new because ARMC5 was more or less constantly associated with severe Cushing syndrome, but it appears that it is not systematically this way. And also, some ARMC5 patients had only 1 nodules on each adrenal. So if we had applied in routine practice for the indication of ARMC5 screening those criteria, some ARMC5 patients would have been missed. So to maintain a 100% sensitivity, we recommend, for index cases, the ARMC5 screening for patients with bilateral adrenal nodules and evidence for autonomous cortisol secretion. It raises only by 5% the mutation rate, but actually, we could have avoided useless genotyping in around 25% of patients in this series, so that's quite significant. Does it help to establish non-invasive diagnostic criteria for PBMAH? Unfortunately, no, because in this 260 patients with bilateral adrenal nodules and autonomous cortisol secretion, it may have some bilateral adrenal adenomas, misleading for PBMAH, but some patients were not operated, so without definitive histopathological diagnosis. We have listed all the known germline mutations of ARMC5 reported in the literature and identified in our center and not yet published. So there is 146 different germline variants known at present. They are spread all over the coding sequence without clear hotspot. And if it's quite easy to assign a pathogenic nature to truncating variants such as nonsense or friendship variants, it's way more delicate for missense variant, representing almost the half of all the variants. So with this paper, we try to give practical tools to geneticists and endocrinologists to decipher between benign polymorphisms and pathogenic variants, notably for missense variants. Before 2013 and the publication of the paper in New England, ARMC5 had never been reported in human disease. But now, 10 years after, 11 years after, we know some things. So ARMC5 is a tumor suppressor gene. ARMC5 has a pro-apoptotic role, so meaning that when ARMC5 is inactivated, cells do not go into apoptosis. This explains at least in part at least in part, the tumorigenesis, the adrenal tumorigenesis in patients with ARMC5 inactivation. And ARMC5 also regulates the expression of steroidogenic enzymes. When you silence ARMC5 in cell cultures, you see actually a decrease of the expression of many steroidogenic enzymes, which is surprising. We would have expected the opposite since ARMC5 mutated patients had hypercortisolism. So we hypothesize that despite less efficient steroidogenesis in one cell, the global increase in volume of the adrenals leads to Cushing's syndrome. The most recent things that we've learned about ARMC5 function is that ARMC5 is actually an adapter of choline ring ubiquitin ligase complex. This means that it binds some substrates to be ubiquitinated by the complex and then degraded by the proteasome. So that makes ARMC5 an important regulator of transcription, cortisol, cholesterol synthesis, steroidogenesis, and oxidative stress. There is many papers released in the last 2 years on this subject, and new substrates of ARMC5 are discovered constantly. We wanted to push further the molecular characterization of PBMAH, so we conducted a multi-omic analysis of 50 tumor samples from 36 PBMAH patients, and using RNA sequencing, near-known and methylome, we showed that ARMC5 patients in blue clustered in all the analyses and forms a very homogeneous molecular group. This was also the case on the chromosomal alteration, because we saw recurrent loss of heterozygosity of the short arm of chromosome 16. So ARMC5 mutations are associated with a more pronounced phenotype and a specific molecular signature. But we noticed also a recurrent loss of the short arm of chromosome 1 in a subgroup of 6 patients, 6 female patients, who also were clustering together on the RNA sequencing analysis. We performed an exome sequencing in these patients, and we found germline inactivating heterozygous mutations of KDM1A, a new gene. And if we look closer to the RNA sequencing analysis, we saw that KDM1A was the most underexpressed gene in this G2 group, the group in red here. And one of the most overexpressed gene was GIPR, encoding the GIP receptor involved in the food-dependent Cushing's syndrome, which has been described more than 30 years ago and characterized by a low fasting plasma cortisol, increasing dramatically after food intake. And this is mediated by the aberrant expression in adrenocortical cells of the receptor, the GIP receptor. GIP is produced by the K cells from duodenum and jejunum after food intake, and it binds its aberrant receptor in adrenals, and here it will act exactly as ACTH on ACTH receptor on the stimulation of cortisol secretion. KDM1A encodes a histone demethylase, which demethylase histone 3 on lysine 4, so it is considered as a transcriptional repressor. So we can speculate that a normal functional KDM1A normally represses GIPR expression in adrenocortical cells, and that this inhibition is lost in case of inactivation of KDM1A, and thus leading to the aberrant expression in adrenal of the GIP receptor, leading to food-dependent Cushing's syndrome, but it is not demonstrated yet. after identifying the KDM1A mutations in a very limited number of patients, we wondered how frequent KDM1A mutations would be in a larger series of PBMAH. So we recruited 301 PBMAH index cases with autonomous cortisol secretion from 8 centers from France, Germany, US, and Brazil. And we performed a germline sequencing of both ARMC5 and KDM1A. We found 10 patients with 9 different germline variants of KDM1A, representing 3% of the series, while ARMC5 still represented 20% of the series. KDM1A patients were all women with some insight, little insight, but more than 80% of the reported cases of KDM1A mutations are women. They all had a food-dependent Cushing syndrome, while no food-dependent Cushing was diagnosed in the 2 other groups, namely wild type and ARMC5 mutated. KDM1A patients had also were also younger at diagnosis. The Cushing syndrome was probably more severe, at least regarding the results of the 24-hour UFC. And consistent with the food-dependent pathophysiology, the morning fasting cortisol was lower than in the 2 other groups, while the midnight plasma cortisol was higher. So logically leading to a very, very decreased morning over midnight plasma cortisol in these patients, as illustrated in this figure here. Using a threshold of 0.5 for this ratio, so morning over midnight plasma cortisol, this holds a 100% sensitivity for the detection of a food-dependent Cushing syndrome and then a KDM1A mutation, but it still has to be, that makes it a good tool for the first screening, but it has to be, of course, corroborated by the result of the stimulation of cortisol secretion by oral glucose load or mixed meal. Well, does it help to establish non-invasive diagnostic criteria for PBMAH? Still not. So we recommend the germline screening for KDM1A variant in PBMAH index cases with food-dependent Cushing syndrome, and of course to all first-degree relatives of KDM1A pathogenic variant carriers. But our colleague from Birmingham, led by Cristina, has recently reported a very interesting case of a patient diagnosed during her pregnancy with a unilateral adrenal mass and severe cortisol and androgen secretion, misleading for an ACC, and it was actually unilateral macronodular adrenal hyperplasia, and this patient harbors a germline KDM1A mutation. So this is the first description of KDM1A associated unilateral adrenal hyperplasia and the co-secretion of cortisol and androgen, which is very unusual. Dr. Florian Violon, our adrenal pathologist in Cochin, has conducted a very interesting study about the somatic molecular heterogeneity in PBMAH. So he sequenced ARMC5 in the adrenal nodules of ARMC5 mutated patients and KDM1A in adrenal nodules of KDM1A mutated patients, and found that ARMC5 patients had a very, very high heterogeneity in their somatic molecular alterations, whether by loss of heterozygosity of the short arm of chromosome 16, or point mutations or deletions, all of these leading to the biallelic inactivation of the gene. And in contrast, in KDM1A, the second event, the somatic event, was constantly loss of heterozygosity of the short arm of chromosome 1. So it's very different in these two genetic causes. He also released last year the first histopathological classification of PBMAH, dividing PBMAH in 4 subtypes based on the presence or not of residual adrenal between the adrenal nodules, but also with the presence of round fibrous septa mimicking micronodules, outlines of micronodules within the macronodules that were present in subtypes 1 and 2 and absent in the 3 and 4. This was also associated with different cellular population and different pattern of immunohistochemistry. And those subtypes were strongly correlated with the genetic background, since most of ARMC5 patients were in the subtype 1, and all KDM1A patients were in the subtype 2, while the wild-type patients were spread in the subtype 1, 3, and 4. We can wonder if, finally, we are talking about the same disease. So if we consider ARMC5 patients and KDM1A patients, they are very, very different in many ways, but they share some common patterns, including the absence of co-expression of HSD3, B2, and CYP17A1, which is contrasting with what is observed in adrenal adeno. So does it help to establish non-invasive diagnostic criteria for PBMAH? No. I will have a quick word on terminology, because the disease that we are talking about has been named with various names in the 60 past years, and in the 90s, the community harmonized the name with the use of ACTH-independent macronodular adrenocortical hyperplasia, AIMAH. But this name has been dropped more than 10 years ago now, following the identification of the finding of a local production of ACTH in adrenal nodules of PBMAH, participating in a self-stimulatory loop of cortisol stimulation. And after this paper, André Lacroix from Montreal proposed to use the term of primary bilateral macronodular adrenal hyperplasia, which is currently still used, but in 2022, the WHO update of the classification of adrenal tumors has recommended to use the terms or the term of bilateral macronodular adrenocortical disease, BMAD, for 2 main reasons. First, in the light of what we discovered about PBMAH recently, it's quite obvious that actually nodules in PBMAH are distinct clonal proliferation and not global hyperplasia, and it also avoids the confusion with ACTH-dependent causes of adrenal hyperplasia, especially congenital adrenal hyperplasia. So I asked Florent Violant, our pathologist, to explain to me what he considers is hyperplasia and what he considers a benign tumor. So hyperplasia is an increased organ size, increased cell number, with normal cells in microscopy and able to respond to stimuli. Well, PBMAH has increased organ size, increased cell numbers, normal cells in microscopy. This is disputable. And they are, yes, also able to respond to stimuli. Are they benign tumors? They are neoformed mass, yes. This is autonomous proliferation, yes. With abnormal cell growth or death, yes. With no invasion, or metastasis, yes. And no recurrence if complete surgery. To my knowledge, there is no report of recurrence of PBMAH after surgery, but I never say never. So he thinks that BMAD, D for disease, is appropriate terminology to use for PBMAH, and it also avoids to use the word tumor, and we have seen recently how the semantic shift from pituitary adenoma to pituitary neuroendocrine tumors has divided the scientific community, so BMAD seems to be adequate. So what have we learned in the past 2 years about ARMC5? We have defined its screening indication, so bilateral adrenal macronodules with autonomous cortisol secretion. We have learned new protein function as it appears as an adapter of occludin ring ubiquitin ligase complex with multiple substrates. We know now 146 different germline variants, including 50% of missense variants. ARMC5 mutation are strongly associated with histopathological subtype 1 and shows a high somatic molecular heterogeneity. I didn't mention the associated tumors of ARMC5 and KDM1A, but ARMC5 has been demonstrated to be the molecular cause of some cases of meningioma. So this is something that we keep in mind during the follow-up of our ARMC5 patients. For KDM1A, we discover this tumor suppressor gene as the molecular cause of food-dependent Cushing syndrome. This is a rare cause of PBMAH, probably less than 5% of all PBMAH index cases. This is mutually exclusive with ARMC5. The screening indications are the presence of bilateral or unilateral macronodular adrenal hyperplasia with evidence for food-dependent cortisol secretion. KDM1A mutations are associated with histopathological subtype 2 and show a very high homogeneity at the somatic level with only loss of heterozygosity described to date. And KDM1A has also been related to monoclonal gammopathy of uncertain significance and multiple myeloma. And in our patients, there is one family with severe history of multiple myeloma. There is, of course, pending questions about ARMC5. It might serve as an adapter of other substrates, maybe in other complexes. We do not understand why it is so heterogeneous on the somatic level. And a very challenging point is still to decipher between benign polypartisms and pathogenic variant for missense variant. For KDM1A, which is very unusual, it's a sex dimorphism. So, as I said, more than 90% of KDM1A patients with Cushing syndrome are women, which is very unusual for autosomal inherited disease. It has to be addressed. We don't know yet. It has not been demonstrated the mechanisms of the overexpression of the GIP receptor, and we could speculate that GIP receptor would not be the only dysregulated gene in this disease. And contrary to ARMC5, we don't know neither why the somatic event is constantly a loss of heterozygosity. But ARMC5 and KDM1A represent only 25% of index cases, so of course we are still seeking for other causing genes. Does it help to establish non-invasive diagnostic criteria for PBMAH? No, maybe there is some clue with this very recent paper published by a German team. They have tried to delineate Cushing syndrome from LC controls and also the different causes of endogenous Cushing syndrome using urine steroid metabolomics and use of 36, I think, different urine steroid metabolites. So this gives 5 different metabotypes with some overlap, as you can see, but they were able, with the selection of a limited number of metabolites, to predict quite accurately the diagnosis of PBMAH in 2/3 of patients. So that's a beginning, that's preliminary result, but we can hope that with refining their techniques and their analysis, maybe someday with just a urine sample of your patient, you will be able to say if it's PBMAH or something else. So I would like to thank all the Department of Endocrinology and my research group and all our collaborators around the world, and you for your attention.
My goodness, so much to think about. Thank you very much for an extraordinarily broad and comprehensive talk. Time is precious, but maybe there's some one or two burning questions that I will run around with the microphone, give me away.
Can I ask a question? Thank you, that was a fascinating talk. Could you just have a few words on treatment? Because it used to be about adrenalectomy, but I think this is shifting now because we've got the genesis inhibitors available.
I didn't mention this because we have nothing very new regarding the treatment. Historically, the treatment was bilateral adrenalectomy. Many teams have tried unilateral adrenalectomy or mostly the tubular adrenal with some interesting results. It allows at least to delay the adrenal insufficiency, but sometimes the contralateral adrenalectomy is necessary. But indeed, many of the that will be game changer for all patient causes, I guess, but PBMH in bilateral adrenalectomy is a game changer. Methalarapone, we use a lot in our patient, but it's a lot of pills, not that well tolerated, since we have observed that less and less patients undergo surgery.
Thanks for that. So in the UK, we've got this thing called G-Notes, where we're able to do gene testing in the clinic, mainly for MEM1, all the big things. And I think the next speaker, Cristina, actually has written the preliminary document. But in your practice, when would you think about actually doing the gene test? Because it looks like, you know, the recurrent bit is it doesn't actually help that much in terms of management. So when would you suggest that we actually check for these genes in clinic? Because we can, because of mainstream testing.
So you understand who should be screened for?
Yeah, when would you think about doing somatic testing for these genes, these two genes that you found in
the somatic testing, you mean? Not the germ, the blood.
Germline and somatic. When would you think about doing genetic tests in a patient with bilateral adrenal nodular disease, which is a really common thing in clinical practice, right? You'll see 3 or 4 a week. So when will we think about actually screening?
In our center, we do it for every patient with bilateral adrenal nodules and autonomous cortisol secretion. We have 20% of IMC5 mutated patients, which is like a lot for a genetic panel. In contrast, on our genetic panel for hyperparathyroidism, only like 2 or 3% of patients will have the pathogenic variant. So we, in a rare disease with a mutation rate of around 20%, I think it's worth it to propose it to all patients with bilateral adrenal nodules and autonomous cortisol secretion.
Cristina,
yeah, that's what we also do in Birmingham. So we either first to amplify all patients with bilateral nodules or adenomas and autonomous cortisol secretion, and that's what we do.
Can I just ask, the gene looks very complicated. We all love a single point mutation with 100% penetrance, and you can just quote the nucleotide, but that gene's a nightmare, isn't it?
Yeah.
I mean, how many of those variants and the whole screen are truly pathological, and how many are just population variation?
Yeah, I don't know, but there is a gene panel which can be amplified through the NHS. So you're
Swallow it. Okay, not swallow it. Very good. Well, thank you very much for that.
Thank you.
Cristina, you have been very nicely set up by your previous speaker to talk about urine, steroid metabolics, and genetic testing.
Yeah. Yes, I'm pleased to introduce Cristina Ronchi, who's endocrine oncology and consultant endocrinologist in Birmingham. And Cristina has been working extensively on the molecular pathogenesis of adrenal tumors and also on prognostic biomarkers and other drug targets for adrenal cortical cancer. And she's going to give us a state-of-the-art lecture on adrenal cortical cancer. I should also say that she is the president-elect of ENSA, which is the European network for the study of adrenal tumors.
Thank you. Thank you so much for the kind introduction and for the invitation to be here to present this prestigious symposium. I'm happy to talk about one of my favorite topics, is diagnostic and management of adrenal cancer, or ACC. So I've been given the challenging task to talk for about 1 hour, but bear with me, I'll try to keep you awake, and it's shorter than 1 hour. So this is the outline of the talk. After a brief introduction, I will introduce you about the European guidelines for the management of urocortical cancer, especially in terms of diagnostic and management. I'll show you a bit about therapy with mitotain, because it's still our gold standard. So we'll go a bit into the details of both adjuvant and so-called palliative setting. And there will be a bit longer part dedicated to pharmacological treatment of patients with advanced ACC, because here is where there is the most unmet clinical need. And at the end, I will give you a bit of an overview of our UHB, adrenal tumor service, as an example of how we treat patients with ACC. So that's a brief introduction about ACC, which, as you know, it's a rare endocrine cancer with epidemiology of about 1 to 2 cases per million population per year. So it's definitely considered a rare disease. It's generally aggressive, but we will see more about the prognostic classification later. Clinical presentation, about 40 to 60% of patients present with symptoms of steroid overproduction, Cushing syndrome, or virilization in women. So that's a female patient with ACC and androgen excess. In approximately 1/3 of cases, patients have symptoms related to mass effects, such as abdominal pain or fullness, but importantly, 20% of patients are discovered incidentally, so during imaging done for other reasons. So patients are asymptomatic. That's relevant because we receive a lot of referrals for incidentaloma, and I will show you a couple of slides about that. So this is a table taken from the current European guidelines for management and treatment of patients with ACC. So there are 2 versions, one published by the European Society of Endocrinology, collaboration with ENSAT, published 2018. And there is also a version published by the ESMO, the European Society of Medical Oncology, published in 2020, but they are exactly the same. So this is a table that tells us what to do in cases of a suspected adrenal malignancy. So we'll have a patient that has already a suspicion of ACC. So we need to screen patients for all adrenal hormone excess, so screen for cortisol excess, androgen excess, mineralocorticoid excess. And we need to stage the patient, so we need to know about local invasion in the adrenal glands, but also at the level of the thorax and the pelvis. So, but this table is about when you already have suspicion of ACC. But as I said, adrenal cortical carcinoma can be also detected incidentally. So this is the figure taken from the Urine Act paper published in 2020, coordinated by Wiebke, Art in Birmingham. This is a very large multicentric study at the European level, and a total of almost 1,700 patients with incidentaloma have been screened. And as you can see, about 3% were diagnosed as ACC. And that's why, and if you look at the guidelines for the management of vaginal incidentaloma, we have to exclude the presence of ACC in all patients. And how do we do that? We first have to ask 2 questions. Is this potentially malignant? Is this functionally active? So the guidelines recommend to perform a non-contrast CT scan in all patients referred for incidentaloma, and to perform at least clinical assessment and 1 milligram dexamethasone test in all patients, and then also metanephrine, aldosterone, renin, and sex hormones. As you can see here, there are numbers. This is because it's in selected cases. And so once you have done this, you will have sort of 4 different categories, and we will focus on this category, which is the clinically relevant hormone excess or tumors with malignant features at a CT scan. There are also different categories, I'm sorry, that are here in the indeterminate mass. So there are masses that still remain indeterminate after this. And here the guidelines get a bit complicated. So this is a figure 5 from the guidelines. As you can see, you have a number of different options depending on the plane Hounsfield unit and potential heterogeneity of the mass at the CT scan. We don't have time to go into the details of all of this, so if you're interested, you can just refer to the guidelines. But for instance, we have this group here with lesions that are homogeneous, Hounsfield unit between 11 and 20, and a size of the tumor below 4%. And here the guidelines recommend additional imaging, especially FDG PET for further characterization, or interval imaging. There has been some debate if this is really appropriate, considering the number of incidentaloma that we get and how many are actually put in this category. So I wanted to also introduce this picture, which is taken from Harrison, Principle of Internal Medicine, published 2024 this year. So this is a chapter that is by Wilke Art, and this is an alternative proposal, especially for the category of incidentalomas with Hounsfield unit 10 to 20 and below 4 centimeters, so that category where the guidelines recommending additional imaging, and here it's proposed no further imaging. And this is based on the results of the urine act that showed 0% of ACC in this category. So I leave it to you if you want to follow the guidelines or if you want to follow this flow chart. But to do this fully, then I also wanted to bring your attention to this other category. So patient with a size of the tumor more than 4 centimeters and Hounsfield unit above 20. This category is high risk, definitely high risk. The guidelines say discussion in multidisciplinary team meetings and consider swift surgery. This figure proposes additional steps, which is urine-steroid metabolomics, FDG PET, and eventually interval imaging, or directly to surgery, depending on the results of these scans. So again, this is an alternative to the current guidelines. It depends on the availability of these procedures in each center. If you have the USM available, if you have FDG PET, relatively straightforward. But there is no right and wrong. You will need to discuss in the MDT and decide for individual cases. So now you have a diagnosis of ACC, let's say, to remember which are the most important clinical unmet needs. This is a generally aggressive cancer. The prognosis is generally poor, but it's actually heterogeneous and it's difficult to predict. In fact, the 5-year survival rate can range between 20 to 60%, according, we say, to the initial tumor stage. But there are other parameters that we look at and that are important to be considered. Surgery is the gold standard treatment for localized stages, but even if successful, there is a high frequency of disease recurrences, and that's why close monitoring is essential for patient with ACC. But nowadays still relies only on frequent imaging, which of course comes with high radiation exposure. And we have limited both local and systemic treatment options for patients with advanced stages, unfortunately. So going back to the guidelines, these are the two flow charts, and there are two because one is for patients amenable to complete resection, and the other one is for patients with advanced ACC not amenable to complete resection. We'll look first at the first picture, and the first step is a adrenalectomy, of course, and then you go for risk stratification. So you need prognostic factors to decide if your patient is at low intermediate risk of recurrence or at high risk of recurrence. And even before that, you look at the resection stages, because it's important to know if the tumor was completely resected, so R0, or if there is still microscopic or macroscopic residual disease. And the prognostic factors that we look at in clinical practice are the initial tumor stage, 1 to 4, with 4 being metastatic, and the proliferation index, which is the KI 6 to 7. And this is been introduced after 2015. And the three categories we use is below 10%, low aggressive, 10 to 20, intermediate risk, and above 20 is high risk. However, as you can see here in the survival curves, there are patients that are actually considered low risk, but they still have a recurrence and will die within 2 years from diagnosis. And there are patients that are classified at high risk that are still alive after 20 years after the diagnosis. So these parameters do not work perfectly. And that's why it has been already a while that the GRAS parameter, have been introduced. And these are like a combination of different clinical and pathological parameters. G stays for grade, which is a surrogate of Ki67. R stays for resection status, A for age, and S for symptoms. And these are just some publications that already mentioned the GRAS parameters in the literature. But we asked ourselves, what if we combine them all together and we also add the NSAT tumor stage that was not considered in previous studies or was considered separately. So we performed a very large multi-center study across Europe through on behalf of the NSAT, and we collected 942 patients with ACP, a very high number of patients considered the rarity of the disease. And we calculated the SRAS score, and you can see the survival curves. This is the progression-free survival, and this is the disease-specific overall survival. And you can see you can distinguish 4 different groups with different outcome. But that's not the only thing, because does this work better than what we use in clinical practice at the moment? So we use a Harris index, which helps to perform a comparative statistic in terms of the performance of your prognostic marker. And you can see that the SRAS score performed better than both the NSAT stage and the KI 67. And we also looked at the literature, because different combination of prognostic clinical markers have been already proposed in the previous years. These are all mathematical models that have been proposed. And you can see very heterogeneous, both in terms of outcome and predictors that were included in the model. And still the SRAS score performed better than all the previously proposed models, which means SRAS score is the gold standard prognostic factor to beat nowadays. So if you want to propose a new prognostic marker, this needs to do better than SRAS, otherwise it doesn't really bring much more to say. And I just briefly wanted to introduce also this other recent study. It was performed by Emre Sajili, coming from Turkey for a short visit in Birmingham through the EU cost action. And what he did, he looked into our cohort of SGRAS, sort of patients that we used for the SGRAS paper. And he also used an independent validation cohort of 152 patients that were not included in the S-GRAS paper. And he wanted to look at if the S-GRAS parameters still efficiently predict prognosis using robust machine learning approaches. So he used a total of 16 machine learning models, and he compared all of this with F1 score and could demonstrate that, yes, the S-GRAS parameters, both taken individually and merged, is still the best prediction model. And we built up a web app. So this is available online. So you can include your predictors in the app. It will give you an estimation of the progression-free survival and the overall survival. So this is only to be used by healthcare professionals to give you an idea about how your patient is going to do after surgery. So it's not to be used by patients. Just to clarify, leads to misuse. So, because prognostic classification is my favorite topic, so I showed you everything we could do just based on the histological report that is available to everyone. The S-GRAS parameters are easily available in the clinic, easy to evaluate. But is there any space for biomarkers, for molecular markers to further improve the prognostic classification? So the entire community has been working on this since long. This all started with two large multicentric study on pangenomic analysis. So this is one NSAT study, and this is the TCGA paper from the US. And these were was all based on the same pangenomic analysis, whole genome sequencing, microRNA sequencing, so very complex pangenomic analysis based on SNP frozen tissue that, however, is readily available in clinical practice and is also complex, expensive, and time-consuming. So we already realized a while ago that this was not feasible, and so we switched from pangenomic to targeted analysis, and we selected a restricted number of DNA classifiers that could be applied in theory in clinic. However, at least the NSAT study was still based on SNP frozen sample. So we in the lab decided to switch also from SNP frozen to paraffin embedded samples that are available in the pathology department. So it could be more easily applicable in the clinical practice. But still, even the targeted NGS was still a bit too much to be proposed in clinic. So we further reduced the number of genes, and we ended up to select just 6 genes for targeted NGS that maintained a significant prognostic value. And in terms of methylation, we reduced it to just 1 gene. So the hypermethylation in the promoter gene of PAX5 actually is one of the best predictors for prognosis of ACC, much better than all the other somatic variants. And what we are doing now is we are trying to put this in the clinical practice. We have collaboration with our molecular pathology department at UHB in the NHS. So if this works, in the future, you could, when you have a diagnosis of ACC, you have your immunohistochemistry, your histological report as usual, and in addition to that, you have the mutation status for 6 genes and the parallel sequencing for just 1 gene, and you could stratify your patient at high risk of recurrence or low risk of recurrence, better than the S-GRAS. Okay, so that's all about the prognostic classifications, how you classify your patients. And back to the guidelines, they say if you have a patient with low or intermediate risk of recurrence, you consider mitotaine. If you have a patient with high risk, it is mandatory to start treatment with adjuvant mitotaine. And of course, it is also mandatory for patients with not completely resected tumor. So adjuvant treatment with mitotaine is very important. It's the first step that you have to consider in the management of patient with ACC. What's mitotaine? It's a steroidogenic inhibitor and a cytostatic antineoplastic drug that is directed against the adrenal cortex. So it's an isomer of DDD, a derivative of the agricultural insecticide DDT. So this is an advertisement from 1946. If you want, I can tell you the story of mitoten. So it was used, an agricultural insecticide, the DDT, and they found out that dogs were dying because they were in the fields and they probably got intoxicated by DDT. And when they tried to find out why the dogs were dying, they were dying for adrenal insufficiency. So, and that's when the link between mitoten and adrenal gland was started, and then mitoten was used to treat Cushing. This is where it started, but no one knew how it actually worked. And this is a paper from 2015, where for the first time was investigated the mechanism and found out that mitoten is actually inhibiting this transferase, SORT1, which triggers lipid-mediated endoplasmic reticulum stress, and therefore apoptosis specifically within the adrenal cortex glands. And this is wanted to present you some updates from a very recent multi-center study. Again, this was led by the NSAT, but in collaboration also with the US. The ADUVO study, I don't know, someone of you could have heard about the ADUVO study because it has been around for years. But now finally it's completed and published last year. So this was a phase 3 clinical trial aimed to investigate the effectiveness of adjuvant mitoten versus surveillance in low-grade localized ACC. So for the patient at a low risk of recurrence. Because if you remember in the guidelines, it was recommended to consider mitoten, but it was not recommended to use it because we didn't know if it actually works in this category of patients. And without going into the details, but you can already see from the survival curves in 91 patients that at the end, patients that have Ki67 below 10, NSAT stage 1, 2, 3, and R0 resection do not benefit from adjuvant treatment with mitoten. So this is the answer to the question, does it actually make sense to give mitoten to patients at low risk? And the answer is no. So just going back to the guidelines, just to show you, so in this category here, now, in the new guidelines that will be published at a certain point in a couple of years, this will be removed. But mitoten is not only used in adjuvant setting, it's also recommended for patients with advanced ACC. As you can see in the other flow chart, patients that are not amenable for surgery or that underwent surgery but had a recurrence, mitoten is recommended either in monotherapy or together with chemotherapy, and it's usually recommended alone for patients that have a low tumor burden or indolent disease based on favorable prognostic parameters. And this is a summary table that shows you the effectiveness, so the response to monotherapy with mitoten in patients with advanced ACC. So this is not an adjuvant setting. This is for patients that have a tumor or a recurrence or metastatic disease. And as you can see, the large majority of these studies were conducted on small cohorts, except for one, the last one, that was on 127 patients. It's more reliable. Overall, the partial response to mitoten is between 13 and 33%, so which is very low. But it increases up to 60% if we reach the therapeutic window, which is the plasma mitoten levels. So it's very important to reach this therapeutic window, otherwise the effectiveness is extremely low. And the duration of the response was extremely variable. So it really is due to the heterogeneity of the studies. And here is the summary of the last study, the more reliable one, which reports a response rate up to 25%. I just have one slide regarding the issues with mitotin, because we always say mitotin is the gold standard. However, it's not a very easy drug to manage. First of all, has a long half-life and a narrow therapeutic window, which I already mentioned, between 14 to 20 milligrams per liter, and a high degree of dose-limiting toxicity. And that's why we have to measure the plasma mitotin levels constantly to make sure that we reach the therapeutic window, but we are not giving to the patient toxic levels of mitotin. And it's associated with several adverse events. Of course, all patients will have adrenal insufficiency by definition, because mitotin is a cytostatic drug, and so all patients will need replacement treatment for all the time they're having mitotin, and sometimes even longer, because of the long half-life of mitotin remains in the circulation for months, even of years after you stop it. Patients can have toxic effects on the central nervous system or on the liver, and they have a number of endocrine-related effects, and I have a specific slide for that afterwards. And importantly, mitotin interferes with the metabolism of several medications due to the activation of the liver enzyme CYP3A4, and this long list of medications also includes steroids. It's a pity because they undergo replacement treatment for adrenal insufficiency, so you need to double up the dose of hydrocortisone, twice as much for patients with Addison disease. And it also interferes with all chemotherapeutic drugs, targeted treatment, almost everything you have to do with patient. So it's just a take-home message that the management of patient cancer treatment with mitotin needs to be done in an expert center. And this is the slide about endocrine-related side effects. There are a huge number of reviews specifically looking at the endocrine-related side effects of mitotin, because it's a very complex topic. Mitotin can act at different levels, of course on the adrenal cortex, but also on the pituitary gland, so on almost all the releasing hormones, and then peripherally on the thyroid, on the gonads, and also it interferes with the cholesterol metabolism. So this is a recent systematic review and a suggestion of what and when to assess the different endocrine axes. And I like to show these slides because maybe not everyone is aware about ovarian cysts that are more frequent in female patients in premenopausal age that undergo mitotin treatment. And so now going to what happens afterwards. So I say that all patients with ACC that undergo surgery then require close monitoring, so close surveillance. The guidelines recommend a CT tap, so thorax, abdomen, and pelvis every 3 months. So you can imagine how many scans do this patient get over the time. So it's quite a huge radiation exposure also compared to patients with other cancer types. So definitely better monitoring tools are required, and at the moment they do not exist. So I wanted to I have just 2 slides about the liquid biopsy, in particular on cccRDNA analysis, because in general, in the oncology field, this is something that is increasingly being used because it presents definitely some advantages. It's minimally invasive, it's relatively cheap. As you can see here in the picture, this allows you to investigate the presence of circulating cell-free DNA in the circulation, and especially the DNA that comes from the tumor cells that are released in the bloodstream. So what you can test is both the levels of the ctDNA, so circulating tumor DNA, and the somatic mutations that comes from the tumor and that you can detect in the blood. So this, of course, reflects cancer heterogeneity even better than tissue biopsy, because it's more representative of the entire tumor. It also allows you chronological collection, because of course you can collect blood over the time, and so better monitoring tumor evolution and response to treatment, and that's why it's used in other cancer types. In ACC, that's not yet a reality for several reasons, because it's extremely heterogeneous. You do not have driver mutations. You will need a gene panel to test ACC, but this is what we tried to do in collaboration with the University Hospital of Würzburg in Germany. This is our pipeline, what we used to test CCF-DNA in patients with ACC. I'm not going into the details of this, but we did build up an ACC-specific gene panel that allows you to detect somatic mutations in the blood coming from the tumor. And this is the pilot study that we recently published. And this is just to say that this is feasible, that you can measure CCF-DNA concentration in patients with ACC, and these are significantly higher than our control group of healthy subjects, and that you can detect somatic variants in ACC-specific genes in approximately half of the patients with ACC, which is not ideal, but it's better than nothing. So this could be used as monitoring tool for half of the patients with ACC. And this is what we did in terms of CCF-DNA-based biomarkers and their potential role as prognostic biomarkers. So you could see that if you combine levels of CCF-DNA and the presence of somatic mutations, you can distinguish two different groups of patients with worse or better overall survival. And this is one example. This is just one patient. So there's a representative example of how you could use the CCF-DNA analysis for monitoring over the time. So you have here the CCF-DNA concentrations in black and the variant allele frequency for two genes, MEM1 and ZNFR3, which are to recognize this is a specific genes. And in this patient that had an early recurrence at 3 months after surgery, the variant allele frequency remained high, which means there's still tumor there, and increased then significantly when the patient had progressive disease during treatment with mitotin. And so what we are doing now is just continuing on this path, because that was just a pilot study. We had very few cases that were tested over the time. So to increase this number and see if this actually has a role for clinical practice. So now going back to the guidelines and advanced ACC and pharmacological treatment when mitotin alone failed, or for patients with high tumor burden and aggressive disease. In this case, the guidelines recommend systemic chemotherapy, in particular with EGP scheme, which is etoposide, doxorubicin, and cisplatin. So that's the first line treatment recommended by the guidelines. And this came from the very first phase 3 clinical trial ever performed in ACC, which was published in the New England Journal of Medicine in 2012. So you can imagine, compared to the field of oncology, the first phase 3 clinical trial in ACC was in 2012. And this was a randomized trial comparing the efficacy of EDP plus mitotin and streptozotocin plus mitotin, and the most important results was that EDPM induces a longer progression-free survival compared to streptozotocin. However, and that's why we use EDP. However, there was no improvement in terms of overall survival, and the response rate was overall poor, with only 30% of patients responding to treatment. So definitely not an ideal first-line type of treatment. And nowadays, after 12 years, we still have no evidence of biomarkers that could predict the response to EDP. This is a recently published paper I just wanted to show you, because the entire community is still trying to find predictors of response to treatment, both to EDP, but also to other types of chemotherapies in ACC, just to better select patients that could be good candidates and patients that are not. And because for other cancer types, inflammation-based score have been proposed to select candidates for chemotherapy. So we thought maybe this could be a good option also for patients with ACC, because inflammation-based score are easy to find. So they're all based just on full blood count. It's available for all patients that undergo chemotherapy, and in particular, NLR is the neutrophil and lymphocyte ratio, and it's a surrogate of systemic inflammation. And this was just a B-centric study where 40 patients treated with mitoten alone and 50 patients treated with EDP, and mitoten have been included. And yes, we could see a significant difference in terms of overall survival in patients with low NLR, and also a difference in terms of clinical benefit. However, this was a relatively small cohort of patients all considered, and so there is currently an ongoing multi-center study on behalf of the ENSA to better investigate that this is true on a larger scale, because if that's true, this would be an easy way to select patients. So the guidelines recommend in second line after failure of ADP as a second option for systemic chemotherapy, gemcitabine plus capecitabine. This comes from some multicentric studies that demonstrated a clinical benefit in approximately 20–30% of cases, so similar to the efficacy of EDP, not particularly exciting. The good point is that this combination is reasonably well tolerated, but I know that many centers have almost abandoned gemcitabine, capecitabine as second line because the efficacy is not particularly exciting, and again, we do not have evidence of any biomarkers predictive of response to treatment. So from now on, I have a few slides talking about innovative or alternative treatment options for patients with advanced ACC. This is one alternative chemotherapy. This is temozolomide. This is taken from a few publications, all from the group of Brescia, from Alfredo Berruti. The overall benefit is approximately 30–36%. It's not too bad, but this is a very small cohort of patients, just 28. So no clinical trials, no multicentric studies are available. It's really just monocentric. The tolerability is quite good. And temozolomide is quite available. It's an alkylating agent. It's used in glioblastoma already, so it's well known. It is an option, but there are no clinical trials. And this study shows you a little bit more in terms of cellular targets, targeted treatments specifically proposed for ACC. This is a very nice picture that represents the adrenocortical cell. And you can see different receptors on the surface of the cell, and all of them have been targeted by different drugs. I'm not going to show you all of those options, but I selected a few interesting ones. I will talk about lincitinib, which is a dual IGF-1 and insulin receptor antibody. I'll talk about cabozantinib, which is a multi-tyrosine kinase receptor antagonist, and I will talk about immunotherapy. So first of all, lincitinib, this was a second phase 3 clinical trial in ACC, published in 2015, coordinated by both US and Germany. And this was based on very promising preclinical studies, both in vitro and in vivo. The entire community was excited that we finally found something that could work in ACC. It was huge excitement for this phase 3 clinical trial, which was absolutely disappointing, was interrupted before the end because it was not working. You can see from the survival curves, there was no difference whatsoever. However, I want to focus your attention on the waterfall plots. I don't know if you know how to interpret this. These are all single patients, and here is the change in size of the target lesion. So all what is above 0, it means the lesion increased in size, and what is above, below, the lesion decreased in size. And we have 3 patients highlighted in green that had a very long-term response to lincitinib. And considering that lincitinib is an oral drug and it's very well tolerated, so we had 3 responders out of 96 that were exceptional responders. One of them had complete response, so all the lesions disappeared. So the question is, why did they respond and the others didn't? And we don't know, because the patients were not selected according to their molecular background in this clinical trial. So there are no information about the expression of proteins at the level of the tumor in that cohort. And this brings me to talk about targeted treatment and drug targets in general. So unfortunately, ACC is an extremely heterogeneous disease. We do not have driver mutations, we do not have driver pathways. And it's very confusing compared to other cancer types. All of these drugs that target these different either genes or pathways have been tested in ACC and all failed. The maximum response was 15%, and the longer was for duration of the benefit was 6 months. So all of these failed. And why they failed? Of course, they were all small cohorts, all small groups of patients. Very few were systematic and multicentric. Another big reason is the concomitant treatment with maltodextrin. I told you before, it induces the C3A4 at the liver, which means it metabolizes almost all these drugs. So if the patient is on maltodextrin before starting, this will affect the efficacy of all these drugs. Of course, there can be compensatory hyperactivation of other pathways, but also most importantly, never we performed a molecular screening before selecting patients for these studies. So we don't know if there could have been predictive factors for response to treatment. And here I want to focalize your attention on this drug here, cabozantinib. These are the results of an old study on a small cohort of patients and was considered a failure. That's why it was not followed up. However, now, like last month, this phase 2 clinical trial on cabozantinib in monotherapy for ACC has been published. This has been presented 2 weeks ago at the International ACC Symposium at the MD Anderson Cancer Center in Houston, Texas. And as you can see, they could observe a clinical benefit in 78% of patients with a mean duration of the benefit up to 24 weeks, which is much more than we have ever seen. So that's encouraging. However, N18, right? So it's still a small cohort, but it's much more encouraging than before. And they also tested the level for cabozantinib in the circulation compared to mitotin levels. So they could finally demonstrate that patient had no mitotin, no whatsoever mitotin in the previous 6 months, had much higher levels of cabozantinib. So it's definitely true that you have to stop mitotin in your patients if they are progressing and you're thinking of going to targeted treatments. And so why is it so difficult to find targeted treatment in ACC? I told you because they are very heterogeneous. This is a recent review. This shows you all mutations in copy number alterations in potential drug targets. And you can see only very few patients, usually less than 10%, present mutations in these targetable genes. And this is the same in terms of gene overexpression in tyrosine kinase receptors. And again, just very, very few patients present overexpression in this. So we need really to change how do we design our clinical trials, how do we design our studies and perform molecular background pre-screen patients before we start, because it could be that this patient can respond much better than what we thought. Now I have a few slides about immunotherapy. So you know how it works. I'm not going into the details of the mechanism. We have both PD-1, PD-L1, inhibitors such as pembrolizumab or novilumab, or CTLA4 inhibitors such as ipilimumab. So these have been tested in ACC. This is already a relatively old slide that shows you the first 4 studies on avelumab or pembrolizumab or nivolumab, and you can see here this is the objective response rate, ranges from 6 to a maximum of 23%. So quite disappointing. The take-home message from this first study was it's not working. And it's not working for several reasons. 2 proposed reasons are, one is because at least 25–30% of ACC have alterations in the Wnt beta-catenin pathway, and has been demonstrated that tumors with these alterations, with this specific activation, are less responsive to therapy. But another reason is that, of course, the majority of ACC, especially in the advanced stages, will produce cortisol in excess. So it's obvious that immunotherapy cannot work properly in a condition of cortisol excess. So we have to move beyond the single-agent checkpoint inhibitors and attack the intratumor glucocorticoid excess to make immunotherapy work in ACC. And this is a much more recent table. I found at least 4 recent reviews talking about immunotherapy in ACC, because things have slightly changed from that picture. There are 2 more recent studies where the response rate is up to 33%, and there are at the moment 4 new clinical trials on combinations of immunotherapeutic drugs with other type of drugs, such as cabozantinib or mitotin, to target the glucocorticoid excess. So it's no longer that disappointing. There might be space for immunotherapy, but there are no data yet from these combination studies. And these are 2 other aspects of the use of checkpoint inhibitors. For instance, this is a very recent study published from the German group. This is the use of immunotherapy in real life. So what's happening actually if you use immunotherapy as an off-label in patients with advanced ACC, and they demonstrated a clinical benefit of 24%, which is not that far away from EDP, so to say. And this is, I just wanted to show you this recent study because this is a phase 2 basket trial of dual checkpoint inhibitors. So this is nivolumab plus ipilimumab in 21 patients with ACC. Clinical benefit 33%, not too bad. But the reason I present you is because this is a basket trial. So it's not a proper clinical trial. I don't know how familiar you are with the oncology field, but this is a new way to design clinical trial in rare disease. So going a little bit away from the typical design of a clinical trial, because this is not always feasible in rare disease. We will never get the numbers to have a statistical power. So this will never be funded. This will never be approved. So we might switch and use basket trials instead. This is something you might not have heard of. This is called the Spencer study. This is a clinical trial, phase 1, phase 2. It's currently ongoing on a so-called therapeutic vaccine in combination with PD-1 checkpoint blockade. And this is recruiting both patients with metastatic ACC and metastatic malignant pseudocytoma, PPGL. This is currently ongoing in different centers in Europe, coordinated by Paris and in Texas and MD Anderson. And I don't have time to explain to you how therapeutic vaccine work, but this opened since 4 years, is actively recruiting, and the first results have been already presented at the ASCO 2022, and it seems quite promising. So I think we might have some good news from this trial, so stay tuned. There will be more results soon. So to conclude the part about the management, I wanted to remind the importance of collaboration. This is a rare disease. It's aggressive, has several unmet clinical needs. The management clinically needs to be multidisciplinary. This has been clearly stated by all clinical guidelines, the European guidelines, the American guidelines. It's clearly specified that it's not just the oncology and endocrinology. You need adrenal specialist surgeons, you need pathology, you need radiology and radiotherapy, you need the nuclear medicine. So you need to discuss every case, every time they have a recurrence, to discuss what's the best pharmacological or local. I didn't have time to talk about local treatment, but there are several studies on that. But also collaboration and multidisciplinarity is required for research. So that no center can ever produce any advancement working alone. So just want to remind you the importance of networks, collaborative studies, to have a platform that helps to build this up. And that, of course, is the European network for the study for general tumor, the current ongoing EU cost action harmonization. You can have a look at the website. There are a lot of opportunities for collaborations and also for educational activities, for travel grants. And the Adrenal Alliance is the American-Asian alliance. So there's a similar thing like the NSAT in the US and Brazil and Asia. And then I have just a few slides about our UHP model, University Hospital Birmingham. So, and how we actually treat patients with ACC, just as an example of how we do it. So the Queen Elizabeth Hospital, we have different types of dedicated adrenal clinics, both consultant and nurse-led. We have access to advanced surgery, both for liver and thorax, have interventional radiologists for different types of radiotherapy. We offer genetic screening for leaf family syndromes to all patients with ACC, independently from family history or age. And for phase 1 and 2 clinical trials, at the moment, we refer our patient to the Christie in Manchester, but trying to set up a clinical trial unit in Birmingham. It takes some time. This is our adrenal MDT. This consists of 23 core members, which include endocrinologists, nurses, and oncologists, sorry, 2 oncologists, 2 surgeons, 4 radiologists, 1 interventional radiologist, and 2 pathologists. But yeah, here's our link with the universities. It's literally linked by a bridge. So that's the university, that's our QE, so the Queen Elizabeth Hospital, and that's the IBR Tower, where the medical school and our laboratory are based. We do organize several educational activities for junior doctors, medical students, and we have our own ethics to collect clinical data, samples of different types, tumor, blood, urine. And we have our collaborators and the lab team, especially the smart imaging mass spectrometry facility at the university. And we have links, of course, within the NSAT, within a lot of other centers across Europe and worldwide. We have a number of international visiting fellows that come for a period to work with us and then go back to their countries. And we are also heavily involved with patient and public engagement activities. And here I just would like to mention that all of this is not possible without the support of patient advocacy groups that help us in both clinical and translational research. This is us. We also believe in team building. We go to conferences, we bring our clinical fellows, our junior doctors to meetings, we organize regular get-togethers, and that's our adrenal MDT dinner. So all surgeons and pathologists and radiologists. And with this, I sum it up. I take the opportunity to advertise the Simba Adrenal event. It will be in person in Birmingham in February. So registrations are open now. There's a QR code. There is a website. So for all junior doctors, medical students, this is actually organized by medical students for junior doctors. It's not organized by us. but all for medical students. It's an opportunity to see something different. And this is our brand new website, if you want to follow us and see what we organize. And with this, I have shown already a lot of pictures. And I'm happy to take any questions.